Imagine a person suddenly collapses in front of you on a crowded street. Immediately, the environment fractures. People start shouting, someone claims the victim cannot breathe, a bystander guesses it is a heart attack. Everyone looks around, waiting for a person who knows exactly what to do. Faced with sudden physiological failure, an untrained human brain defaults to panic and paralysis. Without a mental model to process the raw data of a crisis, the mind freezes. A trained clinician experiences the exact same environment completely differently. They isolate the noise. Instead of reacting to the panic, they rely on an internal diagnostic heads-up display to continuously evaluate the patient. Survival in a critical medical event relies entirely on replacing chaotic, emotional reactions with a predictable cognitive architecture. Emergency medicine operates on one overriding rule: identify and treat what will kill the patient first. In medicine, this algorithm is called clinical prioritization. Clinical prioritization is the structured process of evaluating multiple physiological threats and ranking them strictly by their immediate lethality. Rather than memorizing random first aid checklists, we are going to build a comprehensive understanding of why these emergencies happen in the first place and exactly how the body breaks down during a critical event. To build that clinical mindset, this course scales across 230 structured lessons, divided into 9 specific physiological and situational units. But we must establish a strict boundary before proceeding. This program explains medical reasoning, pathophysiology, and emergency concepts. It does not replace physical training. Physical emergency procedures and practical life-saving skills must always be learned through certified hands-on clinical training programs under professional supervision. Understanding the medical logic, the underlying why of an emergency, must logically precede the how of any physical intervention. The human body does not fail all at once. It shuts down in stages, with different biological systems failing at highly predictable rates. The structure of this course directly mirrors the chronological speed of fatal tissue hypoxia. Hypoxia is a critical condition where tissues are deprived of adequate oxygen supply, leading rapidly to cell death. This abstract flowchart maps out the fastest mechanisms of death. As you can see at the top, the primary and absolute fastest point of failure is the airway, which is the focus of Unit 2. An airway obstruction is an immediate mechanical blockage. It abruptly halts the intake of oxygen from the environment into the body, starting the clock on terminal hypoxia. Moving down the hierarchy, the second fastest critical failure occurs in breathing and respiratory emergencies, which we cover in Unit 3. Notice the clinical distinction. An airway emergency is a structural blockage preventing air from entering. A respiratory emergency is an internal physiological failure, where the lungs lose their ability to process gas exchange. Clinicians prioritize securing the airway and breathing above everything else. If these top-level systems fail, every single downstream medical intervention is rendered mathematically futile. Once oxygen intake is secured, the diagnostic timeline moves to the next chronological failure point: circulation and shock, the subject of Unit 4. This model illustrates the pathophysiology of shock. Shock is a critical state where a drop in internal fluid volume or vascular pressure physically prevents the delivery of nutrients to vital organs. Severe external bleeding or sudden cardiac arrest rapidly accelerates this circulatory collapse, draining the system and placing unsustainable strain on the heart muscle. This circulatory failure strikes the body's most sensitive organ almost instantly. This brings us to Unit 5, the brain. Neurological emergencies and a sudden loss of consciousness present as the ultimate fatal endpoint of systemic hypoxia. Without circulation, brain cells expire in minutes. The core logic of emergency medicine is interception. A clinician executes specific decisions to intercept and break this exact chain of pathophysiology before it reaches the brain. Biological failures are sequential. They form a cascade that you must learn to diagnose and intercept chronologically to prevent death. Internal system failures are largely invisible. Clinicians must rely on external physical signs to visually and analytically recognize these crises under intense pressure. The primary clinical warning sign for an impending circulatory collapse is hemodynamic instability. Hemodynamic instability refers to erratic, abnormal blood pressure and flow that cannot sustain vital organ function. Similarly, visible respiratory distress and suddenly altered states of consciousness serve as the body's external physiological alarms, indicating that the airway or the brain is failing. However, these critical signs vary drastically across special populations, a physiological variable we analyze closely in Unit 8. A deteriorating pediatric patient compensates for shock differently than an elderly patient. A child's heart rate might skyrocket while their blood pressure remains deceptively normal, whereas an older adult's daily medications might mask those same symptoms entirely. This symptom recognition drives the decision logic of triage, spanning Units 1 and 9. Triage is the rapid sorting of multiple patients based solely on identifying these immediate markers of lethality. True clinical recognition requires you to map external, demographic-specific symptoms directly back to the internal physiological cascade of death. Grasping this mapping process protects you from the most common cognitive error made by inexperienced responders: tunnel vision. In high-stress scenarios, trainees often fixate on gruesome, obvious but non-fatal injuries like broken bones or isolated trauma. This visual fixation causes the responder to completely miss the silent, rapid killers. They stare at a fractured leg while a deteriorating airway or internal shock quietly ends the patient's life. Rote memorization is rigid and fragile. Dynamic clinical thinking is resilient. A memorized checklist immediately fails the moment a patient's condition unexpectedly shifts, or when their symptoms deviate from the standard textbook presentation. Relying on isolated first aid steps without a deep comprehension of the underlying pathophysiology causes delayed recognition and fatal medical mistakes. The scope of this course ensures you develop that necessary comprehension, scaling from individual medical diseases in Unit 7 all the way to mass casualty environmental disasters in Unit 9. Traversing these 230 lessons systematically replaces the human panic response with predictive clinical logic. Emergency medicine is simply applied physiology executed under extreme stress. While this framework will train your mind to identify and process these crises, your hands still require formal clinical labs to master the physical procedures. Mastering this cognitive architecture is the mandatory first step before ever touching a patient. Now that the framework is set, we can begin Lesson 1.